Well, I'm excited. This is a nice intimate group, and I have had the pleasure, I think, of speaking to just about all of you at the hydration station, I think, except you, right? You didn't stop by the hydration station, but welcome. So this will be great. I think we'll just get started, and people trickle in if they do. Again, I'm Maria Karimbakas. I'm a clinical dietitian currently with a home care company, ThriveRx, but my first experience with treating consumers with short bowel was back at the Nutritional Restart Center, which was the first intestinal rehabilitation center of its kind back in the mid-1990s in the Boston area. And it was an idea that Dr. Wilmore and Dr. Byrne had after treating patients at the Brigham and Women's Hospital for short bowel. So it was a 30-day inpatient program where patients came to learn about diet relative to short bowel and weaning TPN in a real controlled environment. It was, I don't think I realized what a gem it was. I mean, I knew how wonderful it was, but how unique. I mean, we'll never see a program like that in an inpatient setting, probably again, because, yeah, you know, in terms of just insurers paying for that. Just hand you a handout here.
Oh, thank you.
You're welcome. But anyway, it was my first introduction to short bowel syndrome, and it's the last group, the only group I've worked with in the world of nutrition. It's just a very rewarding job as a dietitian to be able to have such an impact on, you see immediate results when you, as you all know, what you eat and drink matters. And it's really important to be thoughtful about that. And so many pieces to the puzzle with short bowel, and this certainly is a really important one. So I've had the pleasure of training with some of the, you know, the very best doctors in this arena who've taught me so much. And I've been able to share this information over the years, and it's been really great, and the impact is really wonderful. So what I want to focus on when we talk about diet, and I'm looking forward to your questions as we move through the information, but one thing that's really important, it would be really hard for me to sit here today and talk about diet without talking about the whole picture, because I think what commonly happens is that people get focused on one aspect of short bowel, and diet is obviously my area, but I couldn't talk about diet if I don't talk about hydration and if I don't talk about your bowel anatomy and your medications. So that's sort of the theme that I want to set here and make sure that we all are understanding that it's not just one food or one fluid or one particular thing that you're doing or not doing that's influencing your situation. So many people have stopped by the hydration station and said, you know, oh, these particular fluids don't necessarily work for me. And as we get to talking, it's, you know, trying to understand, is it the fluid that's not working for you, or maybe the fluid is working, but maybe you're not controlling other things in the diet, or you don't know to control them yet. So it's possible that changing your fluid might help you. So it's just so important to try to think more broadly about your short bowel, and to start, the very first most important thing to understand is what your anatomy is. So if it's not clear to you, if your surgeon or your gastroenterologist hasn't outlined for you what your bowel anatomy is, it's really important to understand it, because every part matters, and certainly that's the first thing that I would want to look at if I were treating you, is to understand your exact anatomy, because every part of the bowel has a job in the absorption process, and so understanding what's there and what's not there is so very important. And there have been other speakers that have talked about normal length of bowel, so I won't go through all of that part of the detail. I'm going to kind of pick up after that point, which just to remind you that knowing whether you have, first of all, how much remains, since there's a large quantity of bowel, you can have between 12 and 20 feet of small bowel. That's a large range. So we would never want to be talking about what's missing, how much is missing. You would want to know for you an estimate on how much remains, because just to know that you had 6 feet removed, for instance, wouldn't really tell me very much, because if you only had 12 to start, that's pretty significant. But if you had 20 to start, you may be very unaffected. So understanding that to start is important. And your surgical records should have pretty good information on that. And if not, If it doesn't, sometimes doing an upper GI, lower GI series might help at least get closer to understanding anatomy. And sometimes we do our very best to understand the anatomy, and sometimes we don't ultimately know the answer. Do you have jejunum? Do you have ileum is another very important question. There's 3 parts to the small bowel, as you probably know: the duodenum, the jejunum, and the ileum. And the duodenum is almost always preserved in a short bowel consumer, and then the jejunum is the second part, and you may have some, a little, none. There may be, that varies, and then how much ileum you have left, you may have, again, some or none, or all, depending upon what happened in there. And that really matters because the jejunum does a lot of digestion and absorption, and the ileum can make up for the functions of the jejunum, but it can't work the other way around. So if you're missing your ileum, your jejunum can't make up for it. So that's also another important consideration. So that's the other thing. And then whether you have, as you move down the bowel, there's the ileocecal valve that sits between the small bowel and the large bowel. Some people have the valve, some people don't have the valve. If you have the valve, that can be pretty helpful. It's not horrible if you don't have it, but it's important to know because you're going to be more prone to some other things that somebody else with the valve wouldn't be, like for instance, bacterial overgrowth as a possibility. Things may move through you quicker if you don't have your valve. And then the final piece is the colon. And the colon is 5 feet in length. And there's 3 parts to the colon. And so if you have no colon, obviously important to know. If you have some colon, we want to know what part remains. And if you have all of your colon, then you are very lucky. And that's a wonderful, wonderful, thing that you have, a great opportunity, and where diet can even further make an impact. So that's part 1. And although, again, this is a diet-focused talk, we could never talk about diet without that part and that background, because that is going to influence, why you'd be sitting in a room and you're going to hear somebody say, oh, I can eat that. Somebody else is going to say they can't eat that. Or, oh, I have an iron deficiency and I can't tolerate oral iron. Other patients can tolerate oral iron. So it really makes a difference in what you have remaining. So that's certainly part 1. And then most people, when we talk about diet, think of foods, and we're going to talk all about foods in a minute. But I like to also just talk about hydration, and obviously I'm a big fan of hydration. We did the hydration station, but and we talk a lot about it because although food is critical, hydration, and I don't probably need to tell any of you this, a change in your hydration status is paramount to your overall health. I mean, you can go days without the right calories, but you can't go the days without the right hydration, and that's what's going to put you in the ER the fastest. And so being on top of your hydration and really understanding the signs and symptoms of dehydration. I mean, there are some common symptoms of dehydration, and everybody has their common symptoms, the ones that they're most familiar with for them. There's sort of this long list of symptoms that go along with dehydration, and we probably could go around the room and everyone could tell me, like, oh, I know because I never get headaches unless I'm dehydrated, or my blood pressure drops when I stand up. I know I'm dizzy, I know I'm dehydrated, or I know right away because my urine gets very concentrated and I have a very dry mouth. So those are some examples of symptoms, but what you experience versus what you experience is going to be a little bit different. So honing in on knowing your signs and symptoms is really important, because changes in hydration status can really make you feel pretty crummy pretty quickly. And we're such big advocates of oral rehydration solutions and being on the optimal amount, because that can have an overall impact on your plan, not only how you feel, but if you are on parenteral nutrition, how much volume you require is dictated by how much you're drinking and putting out for stool volume. And so if you can better control the output, then you may be able to be on less volume. Even if you can't make any changes in your need for calories per se, and that may or may not be the case for you, but sometimes just improving your hydration status, one, can help you bring down your stool output. Now, there's 2 huge benefits to that. One, of course, is quality of life, being able to be less, often in the bathroom, less stops along the way to a family party or wherever you're traveling to, has a huge impact on your day-to-day. But second, if you can reduce your output and get better hydrated, then you may be able to use a less volume of parenteral nutrition or less bags of IV hydration. So that's really important. And one thing that having the experience of talking to a lot of consumers over the last couple of days, just hearing a common theme is, it's not just about the type of fluid. Your bowel anatomy will dictate which fluid, but then that's part one. Part two is how you drink it. You can't just get the perfect fluid and sit down and drink a quart of it, because that's going to very much result in usually in diarrhea. So it's one, knowing what to drink, and then how to drink it, and really practicing that. And that's usually a huge change. If you haven't had short bowel your whole life, that's a huge change for most people, because most people drink in response to their thirst. And they feel thirsty, they fill up a glass of whatever they're drinking, and they drink it. And they're done with it, and they move on with the next thing. To carry around a bottle and sip continuously all day long is really a behavior change, and that's a really hard thing to implement. And especially as we get into hopefully warmer weather, it's difficult to do that consistently. So I think that we find some of our younger kids and people born with short bowel or have had it for a long period of time have made the shift a little bit easier. So usually when I'm working with a consumer, it's one of our first priorities is finding an oral rehydration solution and getting them on a schedule that works for them. And figuring that out is partly me getting to know you in order to be able to do that, to find out what your days look like. Because if I'm educating you on what to do for a drink, I've got to know what your days look like, because that's a really important piece. If I'm giving you encouragement on to drink something, but I don't understand what you do every day, what I may tell you may not work for your lifestyle. And if that's the case, you're not going to do it. The reality is if if you work outside and I'm telling you to stay cool and, drink, every hour, but you're somewhere where you can't have a bottle with you, that would never work. Or, whatever your circumstances are. I try to understand those and then implement the change based on your individual circumstances. So that's important for you to say, okay, what's working? Like if you like the taste of an ORS, but you're finding it hard to implement it into your day-to-day, looking at sort of what are the barriers? What prevents you from doing that? Is it that you're out and about all day long? Do you not have the right water bottle? Is it not does it not conveniently sit in the console of your car? Even something as simple as that. If it doesn't easily fit in there, you're not going to take it with you. Do you like your beverages really cold? And if they're not cold, will you not take them along with you? So do you have an insulated bottle for the summer months so that it stays really cold? If you like to fill it up with ice cubes, one strategy is to make ORS ice cubes as well, so that you can just fill the bottle up and it doesn't dilute the solution. So there's lots of strategies. So taking a look at what you're currently doing and what might be some of the barriers to implementing change would be helpful, or at least being able to say, this is what I'm struggling with, so that your clinician can give you some suggestions on how to do that. So that's kind of part two. So,
two things. One is, are you going to talk later about the ingest rate of fluids and what a reasonable...
Yeah, so we can even just do that right now, sure.
Before, on short bowel syndrome, I noticed on one of the studies from somebody they talked about radiation enteritis.
Yep.
And that's what I have. So they say I have short bowel syndrome, which I do, but I have enough. My surgeon had said after he did the last surgery that there was enough bowel so that I wouldn't have short gut, but I have radiation enteritis. So how does that change the things for the
absolutely. And so what I should say with that is so we talked about remaining bowel, but that's part one of it's also remaining bowel, and then function of the remaining bowel is part two, because someone that's had radiation is very different than someone else that's had portions of bowel removed because of an injury to the bowel. And the bowel that they presumably have left is all healthy tissue. So we couldn't, in your case, look at your remaining anatomy and say you should be acting like this because the radiation has done something to alter that. So really looking at what happens for you, and this is where looking at intake and output records would be very helpful. So that would be, pretty significant. The other thing is, oh, that's okay. The other important thing is looking at your overall, I talked about bowel anatomy, but looking at your overall plan to figuring out, like I can't say to you exactly what the volume is that you need versus someone else without knowing your anatomy, but the range generally is for oral fluids for an adult. It really could be anywhere between 1.5 liters and 3 liters. And the one thing that I always say is that more is not necessarily better, and it depends on you. And this is where I wouldn't be able to give you a prescription today for your fluid without knowing your anatomy, because more may not be better. In some cases, more drives out more output, and that gets you more dehydrated, and your thirst increases, and you get caught. It's like the mouse on the wheel. You just get caught in a vicious cycle, and I'm sure many of you have experienced that. So it's finding what your threshold is, and sometimes capping fluid at a certain amount actually gets you better hydrated because you're able to absorb more of that fluid. So that's.
How does that volume though relate to the TPN that, for those that are on TPN, that you're infusing daily? For example, I've got 2 liters of fluid, so is there sort of a recommended daily? I know it's varying, but so how do you need to factor that in?
You do. I mean, you do, except that I like to sort of look at each patient and say, in order to make you independent of TPN. So you're going to need a certain amount of fluid in addition to what you're on for the 2 liters of TPN.
Right.
But with the ultimate goal of reducing TPN, what would you need to drink in a 24-hour period to be off of TPN, even just one day? So that would be important for you to understand that.
So that's your suggestion when you go into it, is that you're drinking that volume and not considering what you're getting from the infusion?
Both, but working up towards, so that you know what that is for the long term, so you have a goal that you're working towards. Now, some people, that more might not result in a good result, and you still may need the fluid. But that is the ultimate idea, is how many calories you're going to need and how much fluid you're going to need to be independent, completely, but also it's not all or nothing. We as clinicians want to think about your plan as any reductions in TPN can be beneficial. So if we can even get you 1 day free, 2 days free, starting in those increments. So that is that piece as well. And then the other thing is just before I jump to diet, the last piece is just understanding your medication regimen and what you're on and why you're on it is very important. There's antidiarrheals and anti-secretories that can greatly improve your situation with your bowel function. And so it's important, even as dietitians, to know what you're taking for medications, because those medications are going to potentially enhance your absorption of the food and fluids that you're taking. So it's important to understand what you're taking and when you're taking it. And, have you been instructed to take, for instance, antidiarrheals, around your mealtime, a half an hour before breakfast, lunch, and dinner, for example, in order to control the losses at that mealtime. And again, very individual, and everybody has different circumstances, but that's important for you to know your regimen and why you're on what you're on, so that you maximize their effects. Those medications could be very, very important to the whole picture. So,
A pharmacologist told me recently that Lomotil and Imodium,
yes.
and many other drugs, after you've taken them for a while, your body doesn't really react to them anymore. Is that something you find?
I do find that some people do build up tolerances to them, but sometimes it's just that the medications are working. If you were to actually take them out, you would have very different output. So I don't want to say that they don't work at all, and I find that most people, maybe you got to go up on the dose, but to take them out completely, I think, is not a good idea. I think you still benefit from them. Even if the effect is less, I think the effect is still there. They don't become inert and not work at all, has been my experience. But what tends to happen is people begin to get used to a certain stool level, and they think the medications aren't working, or maybe they're having another diet indiscretion or something else is not working in their regimen. They give up on the antidiarrheals and conclude that they don't work and never go back to them. So a lot of times when I start to work with a patient, we revisit that topic just to understand what worked and what didn't work. And sometimes people aren't instructed to take them around a mealtime. They're taking them in reaction to their diarrhea instead of preventing. So just looking at their schedule and when they're taking it, how they're taking it, how much water they're taking it with is really important as well. And so that's why I mention it in the context of this conversation, because if we're going to shift gears and we're going to start to talk about the diet, but if I only talked about the diet and didn't mention all of that, it's like, well, what if you made all these fabulous diet changes, but we're still drinking regular soda? Or we were doing all these fabulous, diet changes, but, never had been instructed to take medications in a certain way. And the same with anti-secretories. Those are your antacids to help with the acid productions in your stomach, which typically are higher after your bowel has been resected. The literature would say that you only need these medications for 6 months to a year. But in some cases, people continue to benefit from those medications over the long term. So to for sure stop a medication at the 6-month mark because you've reached a certain point. If you're still benefiting from it, we'd want you to stay on it and continue to work with that, or to at least, if you're going to come off of it, do it in a controlled way so that you can compare your stool output sort of before and after the medication has been removed. I think that's an important piece as well. So let's talk a little bit more about diet. On the back, you have a table here that we'll work off of, just for simplicity's sake. A couple of things when we talk about diet is that the first piece of this, yeah, I was going to say there's some more there. Yeah, perfect. Thank you. This is where the bowel anatomy piece comes in again. Understanding your bowel anatomy, when we talk about the macronutrients in the diet, there's 3 components to the diet. There's carbohydrates, there's protein, and there's fat. That's what makes up both your oral diet and your TPN. Those are the macronutrients that provide us with energy. And there's been a lot of research to suggest that the composition of the diet should vary based on your anatomy. So you may have heard along the way, if you have a colon, you should eat a different diet than if you don't have a colon. Has that anything anybody's heard before? Okay. So it's small differences, but we're going to talk about those differences because I know I'm speaking to an audience that we have some with colons and some without. But those with a colon are allowed a higher percentage of carbohydrates in their diet. We would say between 50 and 60% of carbohydrates versus 40 to 50%.
50% with colon or without?
With colon. And I'll explain why in a minute. So 50 to 60%.
And with the whole colon, you said there were 3 parts to it?
Yes, with any portion of colon, we would recommend that diet. And slightly less for someone without a colon, 40 to 50%. And we've made that distinction over the years with the research that's been done, because those that have a colon, what can happen is when you eat carbohydrates, some of them are being absorbed in the small bowel. Those that don't get absorbed are going to get malabsorbed and go into the colon. And the colon is a really dynamic part of the bowel in which it can take those malabsorbed carbohydrates and ferment them, and the fermentable process creates short-chain fatty acids. That's more than you need to know, but there's some energy that can be derived from those malabsorbed carbohydrates. That's why we push, so you can actually get reabsorbed calories with that process. And that's why we give somebody with a colon a little bit more. We recommend more carbohydrates. Someone without a colon, you're not going to have that process going on, and more carbohydrates may result in more stool. So we just slightly back off. Now those differences, you're not going to go calculating what a 50% of calorie are supposed to come from carbohydrates versus 40%. That's too detailed for you, but that's just to understand overall why your dietitian may be pushing you in a direction with more carbohydrates or less, depending on your anatomy.
When you say fermented in the colon, I immediately think gas.
Yep, yeah, it's a great question. So there's this fermentation process can be fabulous. There can be a downside to it too. So the gas is one component. There's also those that struggle with bacterial overgrowth. So that fermentation, although a good process, can sometimes, if that balance of what goes on there gets out of control and the bacteria get out of balance, you can end up with bacterial overgrowth. So there's more micromanagement that needs to go on regarding the carbohydrate. But just if we talk in general for a moment, having more carbohydrate versus less is more ideal for someone with a colon. Because to support your calorie needs. Because in general, someone that has colon left most likely has a shorter segment of small bowel versus somebody with an ostomy typically has a little bit longer of a small bowel and no colon. So you will have a chance to absorb your nutrients slightly differently. In the arena of protein's the next macronutrient, and we push protein. Protein is, in general, it's tolerated the same whether you have a colon or not. Protein is sort of universally tolerated. I call it the go-to food. It's what I default to all the time. All we talk about is combining every meal with protein. Everybody does well with protein. It's just, and there's no caveats, meaning, just as I said, colon versus no colon. There's no bacterial overgrowth clause. There's nothing to say about protein other than eat a lot of it because it's going to benefit you. There's just no modifications that I need to make. So I think most people do a really great job combining protein at mealtime. Most people are probably used to eating some sort of protein when they sit down to a formal meal. It's the snacks that I think most people are not used to snacking. Just knowing myself and knowing what's typical, when you snack, you usually grab one food group, pretzels or crackers, a piece of fruit, some one component. Combining a protein is a little bit more foreign. So instead of thinking of it as a snack, you almost want to transition your thoughts to making it a mini meal. You want to make what you're having at, in between meals, just a smaller meal. If you had chicken and rice for dinner, having a smaller portion of chicken and rice as your evening snack would be much better than sitting down with some potato chips, for example. So thinking about it that way will be, because you need higher calories, and so we have to maximize the day. And this whole idea of spreading your calories out throughout the day is really important, because you're not going to, even the perfectly combined meal, if you eat too much of it at one time, it will not be well tolerated. So just like we talked about with the optimal fluid, if you don't, with optimal fluid, even if you've chosen the right fluid, but you drink it too fast, it doesn't benefit you. Same thing with the food. You've got to choose the right foods and then eat them in a nice schedule all throughout the day. So in general, I'll tell people between 4 and 6 meals, and about every 2 to 3 hours, you should be thinking about eating something, ideally.
What about chewing? I've heard about excessive chewing helps when you break down the food, or?
Yeah, it can be tedious. It depends. See, the one thing I think that gets a little bit lost in the short bowel discussions is that you do digest. So you have the enzymes, and if your stomach is intact, you should be able to begin to break down the food appropriately. Now, you are helping the process if you chew a little bit extra, but you may take the enjoyment away from your meal if you're trying to over-chew and it gets a little bit too tedious. So unless you've been told that you have a maldigestion problem, most people with short bowel digest their food okay. They just don't absorb it. So where it gets a little bit tricky is what happens after the stomach, because your enzymes come in from your pancreas into the small bowel, and that process is usually intact in most short bowel consumers. What may be happening is if things are being pushed, like if you're eating a large volume and it moves too quickly through that area, the enzymes might not have had time to catch up and mix with the food. So I never want to say never. Some people do benefit from pancreatic enzymes, for example, but on the whole, not every short bowel patient needs pancreatic enzymes. So you do digest, and you don't have to chew every last bit, but it is not a bad idea to make sure you've chewed your food decently. You don't want to be gulping and not chewing it well. So that is a thought there. So just back to the making the distinctions, and I know I jumped ahead just quickly to protein, but I do want to just make one other comment about the carbohydrate. There are 2 categories within carbohydrates. There's the complex carbohydrates, and then there's simple carbohydrates. And complex are longer chained molecules, and they are things that don't taste sweet. So they're your potatoes, your rice, your pasta, your breads. They're the component of the diet that we want you to eat a lot of. And we want less of the sweet tasting foods, because the simple sugars, although it's a carbohydrate, and you get the same calorie benefit from a simple carbohydrate versus a complex carbohydrate, the bowel does not like sugar. It changes the concentration of your GI contents, and sugar drives up that concentration really high. And what's happening in the bowel is, as a result of that, fluid is needing to rush into the GI tract to dilute that sugar. And that happens in all of us, but because your bowel is short, you don't have time to catch up with that, and that causes what you probably commonly hear as dumping syndrome. What you can relate to is as soon as I eat a piece of cake, I'm in the bathroom, or I'm emptying my ostomy. So there's a huge distinction in the family of carbohydrates between complex and simple. So watching your sugar content is probably the most important thing that you can do within your diet, both in your fluids and in your foods, to control your output. And I'm always asked the question, how much sugar? How much sugar can I have? What do at a meal, at a sitting? And it's not, absolutely set in stone, but in general, we as clinicians say about 10 grams of sugar per meal or snack. And that may be more for someone and less for somebody else. So you have to kind of find your tolerance, but knowing that it needs to be limited. I mean, a regular can of soda has more than 30 grams, as an example. So, one food could be 3 to 4 times that recommendation. So understanding that sugar can be a huge trigger for you. Even if nothing else, controlling your sugar, you should have a pretty significant impact on your output. Now, somebody with an ostomy is even going to see that change further, but somebody with their colon will as well. I mean, you may find controlling your sugar actually helps control, if you're someone that suffers from bacterial overgrowth, you may have better control of your bacterial overgrowth just by limiting your sugar.
So how do you keep to the 30? You said recommended maybe 30 grams. So how do you figure out 10?
10, but you're right, if 30 for the day, if you quickly just.
So how do you figure that out?
It's a great
with
question.
Syrup or honey?
Yep.
Yeah.
So you have to learn how, with the help of your dietitian, hopefully, to read labels and to look at your serving size. So to go right on the label, they're going to list grams of sugar. So, and serving size, and you have to pay attention to both, because if you look and you say, oh, okay, there's only 7 grams of sugar, I can have that. But if you're eating 3 times the quantity listed on the label, you have to adjust for that. So that's an important factor as well. So it gets more detailed, but certainly it's knowing that first is the first step in the right direction, and then you can start to learn slowly how to look at every food. And the nice thing is because it sounds like a lot of work, right? And you're already doing a lot of work. So how do you make time for all this? But you probably have your regular foods in your diet. So if you just slowly kind of, like, for instance, look at your syrup, or look at your different sources of sugar in the house and what you're doing, you probably can get a handle on it pretty quickly if you eat relatively the same most days. I mean, obviously a special occasion is different, but getting into looking at your diet day to day, you probably will figure it out pretty quickly.
Xylitol and those.
Yeah, it's a great question. Xylitol and the sugar alcohols.
OL or OSE is bad.
Yeah, the OL especially. So I'll qualify, yes. So all the alls, the sorbitol, xylitol, those are sugar alcohols. So there's 2 families of sugar replacers. So in response to obesity in the country and diabetes, these sugar replacers have come along to take the place of sugar. And there's one family of replacers that are very short bowel friendly, and those are the non-nutritive sweeteners like NutraSweet, Splenda, and Splenda's okay. The sucralose is okay.
Not according to my doctor.
Well,
Stevia only.
okay. Stevia is the more natural form.
Not that. What's the other one? What's the original one that was in the sodas?
Aspartame.
That's okay.
Yeah, and sucralose should be as well.
She didn't want it.
She didn't like it. Okay. okay. I don't want to go against another provider, but traditionally, sucralose is not in the family of those sugar alcohols. Sugar alcohols are actually designed to be malabsorbed. That's why they don't affect blood sugar levels or contribute to weight gain, and that no one here needs anything that's going to contribute to malabsorption. And even a regular length intestine, as someone with a regular length intestine can get diarrhea from chewing too much gum or eating, there's the sugar-free candies on the market that just can really upset your stomach.
Question.
Sure.
A lot of the artificial sweeteners use dextrose as a flow conditioner.
Okay.
How do you account for that?
Does it contribute to? I don't know if I know the answer to that. They use it, say that again, as a,
Flow conditioner. It's in there
okay.
as a second component usually.
I think
And
if
they
it,
don't give you an amount of how
well, I was going to say, I think though, according to the labeling rules, if it contributes to the dextrose grams, it should be accounted for. So we'd have to go on the assumption it's not contributing if it's not listed under the grams of sugar on the label.
I don't know, because they don't tell you the split.
Yeah. Yeah, that's interesting. I mean, so I don't know for sure.
She avoids anything with dextrose.
Okay, okay.
The other question is, how about high fructose corn syrup?
Yeah, so there's,
It's notorious.
right, it's in a lot of foods, although we're working hard. I think in general, people have, parents don't want it in the food, so we're seeing it come out of more foods, but it's along the same lines of it's just another sugar that we don't want in the diet because the sugar contributes in the same way, certainly. So.
Why do they put that in foods?
It's a sweetener. I mean,
Just
it
to make
just,
it sweet.
yeah. And I
Okay.
think
Just
maybe
to get it
preservatives. We have
labeled
two. I just have to stop and
Cheaper
say
than sugar.
that I have.
Cheaper sugar, okay.
We have Laura Matarese, Dr. Laura Matarese, and Dr. Winkler, Marion Winkler here, who are both highly esteemed, could be giving my talk. And so I want to invite them into the conversation should they want to add, because they're just unbelievable. I'm sure you've heard their names everywhere and read their work. So, but they may have something to add as well. But they certainly know all of this and then some. But there's no, to my knowledge, other than sweetening, and there's no additional benefit. I think it's just easy to work with, and it preserves foods, and
Well,
yeah,
okay,
and it
right.
stands up to temperature. So I think that it's made its way into our diet. But I'm finding a lot of companies are working to get it out, like in bread. Why is it in bread? Now all the labels are saying, no high fructose corn syrup. Well, why was it there to start? So hopefully they're not having a hard time removing it, because I don't think it had a huge place in there before.
So things like sweet and low. And
Yes, so Equal, Sweet and Low, Splenda, Truvia, which is the stevia-based.
I use straight Truvia.
Stevia, yep, but there's Truvia, so all of those are okay. It's really looking out for the sugar alcohols. And they're not going to be hiding. They actually have to be on the label. They actually will put sugars, and if there's any notable sugar alcohol, it is its own line item on the food label. If you want to go to understand how much is in there, if you're not looking at the grams, or you just by looking at the ingredients are listed in order of their significance, their weight in the product. So if you're seeing sugar alcohol as one of the first ingredients, you just want to stay away from it. And anytime, you need to be suspicious of any sort of sugar-free candy, anything that's completely sugar-free, they had to find a way to sweeten it. So if it's not a NutraSweet based, there's probably some sugar alcohol in there. And I really find that some people never think about mints and gum. Those two are huge, especially the way you would eat them. It's just usually several times throughout the day. Those add up. So it's important to be thoughtful about that as well. And people suffer from dry mouth, so it's not uncommon to want to use mints, but you've got to be cognizant of that sugar alcohol. Okay, so we talked about the carbohydrate, certainly the protein, and no caveats there, eating as much protein as possible. Fat is a component of the diet that, yes?
Sorry.
No?
I was talking to Dr. Carvey, is it?
Uh-huh.
Yep. She was mentioning also about lamb is a very good Oops, right, Carol? What was she saying about lambs? I've already forgotten, but
It-
It was-
It's either because it's easy to digest or because people don't typically eat it and so they don't react to it.
Oh, okay.
so she was
She
suggesting
was-
to
I mean,
try
certainly a
lamb.
good source of protein.
Okay.
Yeah,
So just bringing that up.
yeah.
And she said to.
If people
sometimes
like
it's real
it.
fatty and be careful.
Yeah, well, and I think that's where the fat conversation we're going to have right now, so everybody's going to have a different tolerance to fat, and this is one of those, if you have a colon, you may, we might limit your fat a little bit more than if you don't have a colon. And that, the reason why is if you don't have a colon, we're already going to be limiting your carbohydrates, and fat is something that you can do pretty well with. Without a colon, something else goes on, you malabsorb fat, and fat drags with it minerals such as calcium. And if you take away the calcium and it gets malabsorbed with the fat, it's not available to bind up oxalates. Has anybody had an oxalate kidney stone along the way?
They told him not to have oxalates.
Well, I'm a big fan of talking about oxalate, instead of just limiting oxalates, is talking about just increasing the calcium supplementation to bind up the oxalates. The reason he's struggling with that is because the oxalates get absorbed in someone with a colon. They're a non-issue. If you don't have a colon, you don't have to think about oxalates because oxalates are absorbed in the colon. So there's one plus for you. So that's why we let you have a little bit more fat too, because you can malabsorb the fat and it's not going to drag with it something that you need to bind up the oxalates. So it's kind of this whole cascade of events that can occur as a result.
It's a risk for me because I've only got a single kidney.
Yes.
Single kidney,
So it absolutely, they don't want to, absolutely.
Because then I could lose my kidney.
That's right. So, and it's important, and it's a twofold problem because oxalates is one part of the equation, and just being well hydrated is the second, because you're more prone to stones if you're not well hydrated. So, and most of the foods that oxalates are in are foods that we limit anyway, because it's a lot of the fruits and vegetables. So usually cutting oxalates from the diet isn't so difficult. But if it's really hard to say stay away from a particular food that has a high amount of oxalate in it, just increasing the oral calcium to bind the oxalates can be helpful. And so that's sometimes people's way around that. But with the fat, there are 3 types of fat. And there's one that you all need that we all need that we can't get from the diet. And so you've probably heard of saturated fat, and you've probably heard of all 3 of these fats, but it gets a little confusing. So there's saturated fat, there's polyunsaturated fat, and there's monounsaturated fat. So saturated fat is what we find in animal products and, whole milk. Saturated fat is the one that's been correlated with heart disease, and most everybody has been educated on kind of reducing the animal fat or the saturated fat in the diet. I think what gets confusing is that in general, with polyunsaturated fat and monounsaturated fat, if you're not a short bowel consumer, you're hearing a lot about monounsaturated fat, the heart healthy, the Mediterranean diet, eating a lot of olive oil, canola oil. That's the real general focus. Now, not to say those are not bad fats for you, but they are not fats that your body needs, whereas the polyunsaturated fat is one that your body, my body, all of our bodies can't make on its own. So you actually have to get it from diet, or you have to get it from the IV nutrition, the lipids that you're taking potentially in your TPN. You have to get it from an outside source. And because you're malabsorbing, you're more prone to an essential fatty acid deficiency. So although I need it, I don't lose it in the same amount that a short bowel consumer would. So we have to be sure we're supplementing it for you. So if somebody was asking me, can they eat olive oil? Olive oil does not contain the fat that they need. It's not bad, you just don't want to only eat olive oil. It has monounsaturated fat and it's fine, but it doesn't have the kind that your body doesn't make. Does that make sense? So sometimes when I get working with someone, they're only eating monounsaturated fat. And although that might not be a problem today if they're on 7 days of TPN and getting lipids, say 3 times a week, but if we're working to reduce TPN, we want to make sure that we put in the right kind of fat with the plan that hopefully you're going to be on less TPN and we're going to be taking away lipid. And we don't want to create an essential fatty acid deficiency down the line. So I like to get people on the right diet right from the get-go that's going to help them over the long term with the hope that they are going to be reducing their TPN. Whether they do or they don't, you're still going to benefit from those essential fatty acids. And some people, despite being on IV lipid, develop essential fatty acid deficiencies because their output, their loss, is greater than what they're even receiving intravenously. So it's never a bad idea to start incorporating it into the diet from the start.
So these are.
So these are your polyunsaturated. So you're going to find them in things like soybean, safflower, and sunflower oil, and products made with those oils, such as mayonnaise, margarines, oil-based salad dressings. I'm not advocating that you eat salad, but the salad dressings themselves can make great marinades. They can be great for drizzling on, say, a turkey sandwich. So having options, the oil-based salad dressings can be used in other ways, and they can really benefit you. Some people just to flavor, dip in.
What about canola?
Canola is a mono. It's a monounsaturated fat. Yeah, so the coconut oil, I might bring in my colleagues here on the coconut oil, just because I get a little bit unsure about what to say exactly on the coconut oil, because there's a lot of health benefits that are being touted to coconut oil, but it is not a polyunsaturated fat, so you're not getting the essential fatty acid component. But it's not viewed, although there's more saturated fat, it's not viewed negatively either. So what do you?
Something about the trans something or other, I can't remember the word she used, but there's something in the coconut oil that she liked. She's a short bowel specialist.
I'm not particularly biased toward it, so I feel like I don't put people towards the coconut oil as often. Any?
I'm not convinced that it's a good thing. I mean, it's saturated. I mean, at room temperature, it's not.
That's right.
But it is.
So that's why
It's like Crisco.
yes.
Absolutely.
It does.
Yeah, no,
but
I
its,
totally
but its melt point's like about 75,
Yeah.
76. It melts at a relatively high,
Yeah.
low temperature.
Facility is source of MCT. You know, change triglyceride. It's that which your
She
doctor
called something about it.
The MCT.
Something or other is
medium
quicker.
chain.
Me-
Medium chain triglycerides.
Yes.
That's probably what she said.
That's exactly.
And so they're rapidly absorbed, they're easily absorbed, and they don't provide essential fatty acids, but it would be a source of calories.
Right.
So,
And so I think so.
It's one of the things I use. I do use these.
Yeah, well, and I think that's what I was going to say. So if you do incorporate it, just making sure you don't avoid the polyunsaturated fats, yeah, would be helpful.
I think I would only probably recommend it as calories for somebody who's really having diarrhea and
Okay.
yeah, you know, then maybe you would get some benefit out of it, but I would still want it in small amounts.
I don't.
Okay, and not replace. Okay.
Karen and I could.
Yeah. Yeah.
Yeah.
It's
You
true.
go out in the sun.
It is, and the oils, I have to say, we did a little case study on it, and does seem using it topically for essential fatty acid deficiencies. I mean, your skin is a site of absorption. You know, it's an organ, and we can absorb.
Plain oil, right? Not coconut.
No, not coconut. Yeah, just doing the soybean or the safflower for the essential fatty acids is another way. If you're limited in your abilities to absorb,
Just rub it all over.
rub it in a spot that one of the signs of essential fatty acid deficiency is dry, scaly patches on the skin that are stubborn, that you cannot seem to, no matter how much lotion you use, it doesn't seem like it improves. So that would be a spot you'd want to target with the oil to see if you can get it to improve
So
with the use.
safflower oil and
Soybean?
soybean.
Yep.
But Maria, you mentioned about salad, and some people have trouble even digesting anything, but I didn't see, just looking down, I didn't really see anything about fruits.
Yep, so I'm going to cover that because that's a great,
Later?
yeah,
Okay.
yep. No, we can talk about it now. Yep, let's finish on fat and then we'll talk about fruits and vegetables.
We have a bottle of MCT oil.
Mm-hmm.
What do I do with it?
Give it to,
Is that
give
a
it to her.
A bottle of MCT oil.
Give it to her.
So people like it, as Dr. Matarese was saying, people like it because it can't, because it's medium, it's between long chain and short chain, it can get absorbed a little bit easier. But most people find it very offensive in its taste, so it's very hard to incorporate it into the diet and feel good about it. I mean, you can hide it, you can definitely put it in things and hide the flavor. But if you have some tolerance to long chain regular fat, you're probably better off. And I mean, MCT is not only difficult tasting, but it's expensive. And so if you don't need it in there, I think what happens is oftentimes you're told that a short bowel diet is a low-fat diet, and we would rather call it a modified fat diet. It's not low fat. We don't want you to avoid fat. We want you to be really choosy about the fat that you put in there and how you put it in. So combining these sources of fat at every meal and snack is the way to do it. You never want to sit down to a whole bunch of fat at one meal. And as I told you at the beginning of my talk, I had worked years ago at the Nutritional Restart Center, and one of the studies sort of we did informally is just looking at, I don't even want to call it a study, we were just comparing, you know, diets, and you know, you can be eating, you know, I talked about this 50% diet of carbohydrate, 20% protein, and it's about 30% fat. You could be eating a diet of that composition and choosing all the wrong foods and eating them in a way that can promote diarrhea versus eating that same composition diet and spreading it out in a way that you can absorb it really well. So if I had slides, I would show you sort of the two differences. We showed two diets that were the exact same diet composition, but are tolerated entirely differently. So it's really important about what that's why it would never be appropriate to tell you to just go figure it out. You know, now with all these apps, you could go figure out a 50% carbohydrate diet, but how you implement it is so important. So we want to be sure that, you know, you've got all the tools and you're not just told part of the story. So we should stop and talk about fruits and vegetables. As you see on my table, they're not on here at all. Now, in general, we limit fruits and vegetables. Very much against the general American diet, we are not promoting fruits and vegetables. Fruits we limit because of the sugar. It's natural sugar, but it's sugar. And the fruits in general have a lot of sugar, and they're not tolerated in large quantities. Now, that doesn't mean you can never have any. We just would encourage you to have small portions at a time, and you're going to do better, you know, with a banana and maybe some strawberries, some cantaloupe. It's usually the skins of fruits that you need to be very cognizant of. So if you're going to have an apple, for example, you want to peel the apple, and that's because of the fiber. The skin is insoluble, and it does not get well absorbed. And can if you have any narrowed areas of bowel, can cause problems. So that being said, it is just not really recommended. Now, vegetables, you don't have to worry with the vegetables about sugar. They are very low in sugar, but raw vegetables are very high in that insoluble fiber, so they're not very well tolerated. And they can contribute to diarrhea. If you have an ostomy, you would likely find that undigested in the ostomy. But they will contribute to the overall fiber load in your diet and are not, you know, will really promote diarrhea and not very well tolerated. Everybody's range of tolerance is different. Usually a cooked vegetable is tolerated better than a raw. And again, thinking about the quantity. So our general recommendation is a half a cup at a time. And not more than that. A half a cup of cooked carrots or green beans generally are okay. Just not making it the focus of your meal, and certainly you know, thinking about it as truly a side and not a big component of your plate. You want your plate to look more, a lot of protein, a lot of complex carbohydrate, and a small portion. And if you can do without it, you're probably not gaining a ton of benefit. We really leave it in by patient preference. There's no reason to add it if you can do without it. A lot of people say, well, what about the vitamins and minerals that you get from it? We would rather supplement with the vitamins and minerals through tablet form or your IV form, or a combination of both depending on your regimen, instead of eating those foods for the benefit of their vitamins and minerals. Because if you're malabsorbing those foods, you're not getting the vitamins and minerals anyway.
But So what about potassium? You said if you don't eat bananas, so where do you get your potassium?
That's a great question. So it is hard to put you on a diet to get potassium just from the food itself. So a couple of things. If you're really struggling with potassium, you could do an oral supplement. If you're on TPN, we would manage that in the bag initially. But the big thing to understand about potassium is if we can lower your stool volume, your potassium level is going to improve. So, and the other thing is the oral rehydration solutions have potassium in them as well. Now, the Gatorade has the least amount, but the other two that we were sampling, the Drip Drop and the ORS, each have 20 MEQs per liter. So that's pretty significant. But you will find if your output comes down, your potassium levels are going to improve. Okay, and then we talked about oxalates, so and fluid in the beginning. So that's kind of the components of the diet that we think about, and then it's just combining and getting yourself on thinking about eating on a schedule. And probably a lot of you do that already. It takes a lot of planning and eating in intervals all through the day. And if you're on parenteral nutrition, a lot of your calories are coming from there. Your initial focus isn't getting up to, say, goal calories. You want to get on a diet that you tolerate and trying to get your output down. You don't want to be, ideally, you want to be thinking about modifying your diet to help over the long term reduce your output and decrease your IV calorie needs. So going about it slow and steady, if you're someone that doesn't eat a lot right now but wants to eat more, it's quite possible you're going to be able to get there with some careful thought and management around it.
Are there support groups? Because for me, it's very difficult to do a lot of this stuff and still going to work and
Sure.
the situation. Are there support groups outside where?
I know there are several online support groups.
I was thinking about outside
Yep.
people meet or whatever to exchange ideas.
Yeah,
give
and
moral
then in
support.
some regions, I know,
I need moral
Pardon?
yeah, you do.
moral support, something to help keep me
And-
to the
And
diet.
by
Absolutely.
the way, is there anything
Where I lack.
psychologically that can be done, hypnosis or other things people have thought about?
No,
Seriously.
I'm a big, I believe in hypnosis, all of that. I think mind-body is a very important component. It was being talked about this morning. I don't think you'd ever be wrong in thinking about all those things because we're talking here, I've learned even just as a dietitian, I have to understand the psychology of change, and getting people to make diet changes is really big. And understanding, I mean, sometimes if we're missing the mark just on like their ethnic traditions and what's important, you know, and I know I work with consumers all around the country, and you know, just even what they're doing, you know, pig roasts versus, you know, just understanding what they want to be a part of and what they want to tolerate it's different. So you've got to be able to understand what people want to be able to do in order to make these diet recommendations work.
Could you imagine you and your Italian family having this? What would you eat?
Right, it would be hard without, I mean, we eat a lot of, yeah, right, the tomatoes are difficult, the cheese, you know, the lasagna.
Yeah,
Right.
No cheese at all.
Yeah, and some do tolerate some cheese.
I can eat white cheese.
Yeah, and usually the harder the cheese, the less the lactose, and there's some tolerance there. But the softer cheeses, the milk products usually are not very well tolerated. So, but there's a range in terms of what people can tolerate in terms of lactose. Lactose, as you know, is the milk sugar. Some people have zero tolerance to it. Some people have some tolerance to it, and some people don't know what their tolerance. Some people's output's so high, they don't even know for sure what the correlations are. So sometimes start dialing way back and just starting slow and introducing foods one at a time to see what happens. And really, you know, kind of taking a hard look at what you're doing, and you know, if you feel like that's a piece that's lacking, you know, in your care, getting connected to a clinical team with a dietitian is important, you know, just to be sure you're getting everything you need to be most successful.
Jack just asked me this morning, someone told us that hard cheese and cream of wheat
We're two big things.
constipating.
Oh, okay.
And that was an
Like a staple.
old-fashioned way
Yeah.
of controlling diarrhea, is how to use the pig
I think the cream of wheat can be helpful, but I think constipation is a stretch. I think if you're constipated, I'm worried about a bowel obstruction, you know. But I think there are components to that, like the lactose, for example. If you're not lactose sensitive, cheese can be binding. And so it may, and for that person in their anatomy, if they're a short bowel and we're talking, that might be helpful to them. But it isn't any hard and fast. There's nothing special about those foods that's for sure like the magic bullet.
Okay, well, you were just saying have your group of people who help you, what did you call them, your team?
Yes.
Okay, I don't think we really have a team unless the pharmacy that's providing the TPN is also the team.
Right. Well, some people are connected to institutions that have a diet. So we see patients everywhere, and sometimes they're seeing a gastroenterologist and no dietitian. Or, you know, so if they're not, and some people aren't on parenteral nutrition, so aren't getting a dietitian through their home care company either, because they don't have a home care company. So I think that just making sure that your medical team at your institution also, like where, what, like at your doctor's office or your gastroenterologist or where you see. Oh, not necessarily home infusion. I mean, just even like who you see at the hospital, like where you go to get your gastroenterology care.
Gastroenterologist is a local guy.
Okay.
Who mostly does procedures.
Okay.
But he's taken on Jack and he likes Jack. And we're never going to try to lose him, that's for
Yeah,
sure.
yeah.
But
But you're saying
But he
that that's
doesn't
not
have
available.
He doesn't have a nutrition team.
absolutely
and some
not.
of it
And
else.
otherwise, the internist is a guy on staff at Georgetown, so he doesn't really treat anybody unless they're in the hospital.
I see.
Who prescribes the formula?
The gastroenterologist.
So, you know, one of the things you could do is
Talk a little louder.
in your city or in your community, you could call the local hospital, ask for the dietary services, and just ask them, do they have somebody on the staff who's experienced in GI diseases or short bowel? And just
Yeah.
see, there may be somebody there that your physicians are connected with. I would start that way. It's more likely you'll find that at the bigger centers, and it's more likely you'll find them connected to Oley. So it could be that Oley could help you identify a dietitian. There's some other ways to locate dietitians.
Well, I was hoping that we would find someone here.
Where are you?
Outside DC, halfway between my and
Yeah, and she does. I just can't talk about my home care company as part of these sessions, but you do have that through the home care company, but I thought you were talking about through your local doctor.
No, I don't care where.
Oh, okay.
That's where we go.
Yeah.
Lance
Yeah.
Clan Center, not that I
Is he on
He's on TPM with us, yeah,
Oh.
but newly.
works with small bowel transplant.
No, not yet. I'll tell.
So you got the best one.
Aaron.
I
know.
Right there.
Well, where's that?
Yeah.
But I'd like
It's
to
about
know
other
the
people
others,
in that.
because we're certainly not going to.
You know what I found for like products that help
Right.
And Aaron
oatmeal? Thin your oatmeal so
Yes.
you don't have to add any milk to it.
Yeah, I don't have any milk to that anyway.
So
Anyway.
that helps.
You have a question in the back?
Almond butter and gluten-free bread.
Okay.
And with these new connectors that are so small, my concern is being able to get enough food through the tube.
Yes.
But if I have to dilute to get through that small bore, I don't think I'm going to be able to give them enough nutrition.
Yeah.
Is there any suggestions for that?
Is he limited to only, is that his only way? Can he eat at all?
Does not respond well to commercial formula.
Okay, and is that his only mode of nutrition? He doesn't eat at all? Okay. It is, I'm hearing, and enteral is not my specialty, but I'm hearing that this is a worry with these connectors. Again, pipe in if there's something there, that there may be some worry with the blenderized diets and formulas, that they may be thicker than the connectors can handle. But we don't have those connectors, right? So we don't know yet. I know some has made the transition, but not the whole apparatus hasn't changed quite yet, correct? So I think time will certainly tell if that's the case. And you're right, if you have to dilute more and he's volume sensitive, you may have trouble getting enough of calories in the volume that you're used to doing. And so there may be a shift that needs to take place as a result. It's probably not the answer you want, but I think time will tell for sure whether that's going to be a formula that if he can still do what he's doing, and if not, does he have flexibility to increase his volume? And if he doesn't, then what? You know, what are the alternatives for him? Yeah, yeah.
Are you blenderizing the food yourself? I know that this is probably not optimal, and, you know, use a syringe, and put, you know, put some through the syringe. Yeah, right now we grab it, we just use a grab. Yeah, exactly.
And it's a little different, you put them in the water.
Exactly.
And you see how thin that is.
Yeah, I know.
Maria, is there any advantage to trying not to eat and fast for a while and stay on TPN and get all your nutrition going, and then maybe start slowly introducing foods as opposed to now trying to do the whole switch?
Yeah, it's a great question. You know, we never want, the bowel goes through an adaptation process, and we never want people to be without food through the GI tract, because the villi, which is the finger-like projections on the bowel, they flatten, you know, even if it's just a few days without food. So, but eating maybe less, if you don't have control of your output, dialing it down and back, and then kind of increasing slowly from there may be an option, but I wouldn't encourage
So just
stopping.
dial it back.
Yeah, and modifying and kind of, you know, one thing I encourage is like looking at, you know, writing down what you're eating and
Yeah,
drinking,
right.
and, you know, and
What about the hunger pangs? There was talk about that this morning. Is there anything, for the craving or anything like that one can do that sort of satisfies that, or pills, or
yeah.
any kind of thing?
Well, the hunger, if you're,
Diet pill,
yeah,
diet
no,
pill?
I mean, we'd want to maximize your hunger if you're someone that
Oh, yeah, I
has
hear
the
you.
ability to
But
eat.
you've got the psychological problem.
Yeah.
You're hungry and you're going to grab something to eat. It's not as simple as just.
Right. Well, but you have, it's not like with the person that was speaking this morning where she physically can't eat. We would actually want to just be really cognizant of what you're eating and try to get you to absorb as much of it as possible by being really choosy about the food, because you can eat, and maybe by doing that, you're going to be able to need less of the TPN. So that would be our hope. So.
You know, instead of a cracker,
Yeah.
or instead of a sweet, a quick fix that people normally would go to when they're hungry, get something with the protein.
Protein. Turkey. Yeah, and adding the protein can be so beneficial. Adding the protein can be so beneficial.
But here's my problem.
Just as you were saying.
I've had diarrhea for 11 years. I've had diarrhea since 2005. I was on TPN for 6 years, off. I'm back on for we don't know whatever reason. I'd rather right now get rid of the diarrhea and rely on TPN first, and then work it, versus trying to get rid of the diarrhea and reduce, at the same time, try to reduce my TPN. So is that a viable plan? And how would I approach that, or would I approach that?
Yeah, because I think one thing I try to do is understand what people's priorities are. If you're more concerned about if quality of life improvement would be, would be being in the bathroom less, then that would be our focus first. And if reducing, because some people I have found, you know, it's a small number, but some people aren't particularly bothered by the TPN. If they could just be in the bathroom less, they would see that as an advantage. So trying to get at what the goals are first is always a first priority. Absolutely. Yeah. I don't have a watch on. Are we at our time? Okay. So does everyone feel like they're gotten their individual questions answered that have questions?
I think
I know, that's the only downside. There's so much information, but you're not supposed to walk away and feel like you're supposed to have mastered this.
Depend on some other people.
That's right.
Your
It's,
own care,
yeah, it's a one.
wherever they may be.
This is a 101. This is to get you thinking about it and thinking about some proactive changes to help you meet whatever goals you're trying to meet. And I know that's different for everybody. So,
This is being taped, correct?
yes.
And how do we get to view it?
You know, I don't know the answer to that. If you all get to
They
view
said
this or
It
not,
will be on the Oley website. They'll have all the videos from these sessions, I believe.
on the,
big ones with the
okay,
presentations. It may take a few months, it probably will, but they'll get them on their website eventually.
okay.
So, yeah.
But
I didn't know ahead that I was being recorded.
I hope you signed that little thing that said it was okay, right?
Yeah, yeah, he told me when I walked in, but I mean really ahead, like I didn't know coming in, but that's fine. It's good if someone else can benefit. I know there's a lot of great
What a different
sessions
outfit though, right?
to choose. Yeah, maybe. I had my dress on yesterday. Most, you know, there's so many great sessions going on. Not everyone can take advantage of being at every session they want to be at. So it is nice when they're recording. So, good. Does everyone feel good about? And if, you know, feel free to stop me if there's something I didn't cover or. Oh,
Yeah.
alcohol.
The elixir.
Yeah,
God.
yep. So the difficulty with alcohol, it's one of those things where we just, can be part of, you know, on a limited basis. We would never say never, just to remind you that it's not hydrating, not that you don't know that already, and that it's taking the place of other, you know, nutrient-dense foods or fluids or hydration fluids. So just being mindful of that. But again, socially, if you can tolerate it, we wouldn't want to say never to have it. But the biggest thing is the hydration piece, is knowing that it can be.
So just drink more beer before you start drinking liquor. Something like that.
Well,
All
not.
right, so drink more of your your ORS.
Well, you would
right
have to
before
be.
you have it.
That's right. You'd have to be alternating ORS and alcohol.
Or, we said, put your drink in your ORS.
There you
Or in
go.
your ice cube. Your ice cube, yeah. That's what you do, you put it in your ice cube.
So maybe next year
That's really good.
at the hydration station, we'll have that going.
In fact, at home, my
Did you
wife.
hear what she said?
What?
Yeah.
Say it again.
It's like your ORS tastes really good if you've had a little bit of vodka or margarita. It's left in the glass, then I just fill it up
Yeah.
with my.
Well, by the
and
way,
add
the last
extra
3
lime.
months, I started getting vodka, and my wife won't let me drink tonic water, so I just have G2. But you can't get it at a bar. You can't go in and get a vodka and G2.
Well, maybe we need to have an Oley cocktail hour next year with hydration beverages.
Yeah, but I tell you
I think I get my Oley card that said I've got a special diet or something here.
Yeah, but the Juanes brothers drip drop because they got the lemon and the and I make mine up with raspberry lemonade.
Yeah.
And then you add it to the vodka.
Yeah, well, that's the same thing you were
Well,
talking
yeah, and you can take right in with you one of those packets
Yeah. Oh,
and
yeah,
make
you're
your
right. Just take it in.
take it in, and then they have them add the vodka to it. So, where there's a will, there's a way.
That's a good point.
Yeah. So,
Thanks.
thank you for all attending, and I hope I've addressed your questions. And thank you.
So I guess you'll call
Thank you.
us.